You are welcome to this session. We shall be discussing obstetric fistula. My name is Munirudin Aderemi Ijaya. I'm a professor of obstetrics and gynecology, a consultant obstetrician and gynecologist, fistula surgeon, and a public health physician. I work at University of Ilorin and University of Ilorin Teaching Hospital, Ilorin, Kwara State, Nigeria. Obstetric fistula is a common condition in developing countries. It is rarely encountered in the developed world as a result of their good healthcare facility. It is a major public health issue in developing countries. So these are the learning objectives. By the end of this module, the learners are expected to be able to define obstetric fistula, describe the epidemiology/risk factors of obstetric fistula. They should be able to list the causes, explain the clinical presentations, list and interpret investigations, and describe the treatment options of obstetric fistula, and explain the preventive measures of obstetric fistula. Obstetric fistula is a preventable calamity which has been an age-long menace in developing countries. It is as old as mankind and has been a continuous source of misery to the afflicted women. It is defined as a genitourinary or recto-vaginal fistula occurring after labor and its complications. World Health Organization defines obstetric fistula as an abnormal connection between vagina and bladder, and between vagina and rectum, which may develop after prolonged obstructed labor and leads to continuous urinary or fecal incontinence. Vesicovaginal fistula is the commonest of them all. It is the connection between the bladder and vagina. Then the other one is rectovaginal fistula, which is the connection between the rectum and vagina. Sometimes the two occur together. This diagram illustrates vesicovaginal fistula. If you look at this is the bladder, urinary bladder where the urine collects, and this is the vagina. In normal situation, both are separated by this septum, the anterior vaginal wall and the posterior wall of the bladder. When there is communication between this bladder and the vagina, this is where the defect is, then now say the person has developed vesicovaginal fistula. So if it's affecting the posterior vaginal wall here and the anterior rectal wall, and there's a connection between the two, then that is rectovaginal fistula. Uterine fistula is another form of it, where there's connection between the bladder and the uterus. We have cervicovesical fistula, if it's affecting the bladder and the cervix. They also have ureterovaginal fistula, if the connection is between the ureter and vagina. So for every maternal death, about 20 to 30 women develop serious obstetric complications. Among them is obstetric fistula. And obstetric fistula is usually follows prolonged obstructed labor, and this accounts for about 8% of maternal death. So among those people that survive, the survivors of obstetric fistula, of obstructed labor, that develop obstetric fistula, then you can now say that they have had an aftermath of a near-miss maternal death. Obstetric fistula is a preventable condition, but it is still prevalent in developing countries due to high level of poverty, illiteracy, ignorance, and poor utilization of inadequate health facilities. This condition is regarded as the most devastating and dehumanizing condition to afflict women. The prevalence of obstetric fistula is a reflection of quality of obstetric care in a community. So where there is poor obstetric care, we expect to see high prevalence of obstetric fistula. It is an issue of public health concern in the developing world. Historically, obstetric fistula was thought to be incurable not until 1675, when Johann Fatio performed the first successful VVF repair. In 1849, Marion J. Sims achieved his first successful fistula repair at his 38th attempt. That tells you how difficult it is to repair vaginal fistula or obstetric fistula as a whole. It is always reserved for the people who are skilled in the repair of this condition. It is this same Sims that popularized the repair of VVF, and he was regarded as the greatest of all fistula surgeons and the father of modern gynecology. There is a wide difference in incidence/prevalence of obstetric fistula between the developed and the developing countries. It is rare in developed countries as a result of good obstetric service. Most cases are seen in developing countries. In Africa, Middle East, Asia, and these are the areas that have the high maternal mortality ratio. There is a region where it is confined to, which we refer to as fistula belt. They occurs across the northern part of sub-Saharan Africa, from Mauritania to Eritrea, and the developing countries of the Middle East and Asia. The incidence and prevalence of obstetric fistula. There's conflicting incidences/prevalence reported in literature. Many of these cases are underreported because most of the cases that we see, they occur outside the hospital. They are seen in the remote areas, and most of them are ostracized. So they are, so to speak, they are hard to reach people. So it's difficult to get data from such condition. The methodology for community cited incidents. The methodology for the commonly cited incidents has been challenged. The common ones is quoted as 1 to 2%, and it is also estimated that about 50,000 to 100,000 new cases occur yearly, with global estimate of 2 million people living with fistula. So the methodology for all these incidences and prevalences I'm quoting have been challenged. So other researchers have also worked looking at some of the population studies, the meta-analysis, and systematic review. Adler in 2013 did a systematic review and meta-analysis, which included population-based studies. So the pool incidence was 0.29 fistula per 1,000 women of reproductive age. For sub-Saharan Africa, we got 1.60 fistula per 1,000 women of reproductive age. And for South Asia, 1.20 fistula cases per 1,000 women of reproductive age. Su et al. Reported 2.11 per 1,000 births for Nigeria, while Agenda F estimated about 12,000 new cases of VVF occur annually. The range of obstetric fistula for studies done in Nigeria from different centers is between 84.1 to 100%. At University of Ilorin Teaching Hospital, we got 84.1% of all the fistula cases encountered. There's more prevalence of obstetric fistula in northern Nigeria than southern Nigeria. Now look at the risk factors. The risk factors can be explained by the 3 delays that contribute towards poor obstetric outcomes in obstetric labor. This was described by Mane. So some of the risk factors include teenage pregnancy and primigravida. There is higher incidence of obstetric fistula among teenagers. Where early marriage is practiced, we have higher incidence of obstetric fistula in such community because the pelvis is not matured enough for vaginal delivery. People of low socioeconomic status are also more prone to developing obstetric fistula. This is because of high level of poverty, poor empowerment of women, lack of education. All these encourage early marriage. Malnutrition also leads to short stature and inadequate pelvis. Where people believe on women take permission from their husband or family member as a surrogate husband, where the husband is not available, before they can go out to seek emergency obstetric care or go for antenatal care or fertility delivery. Places like that have a higher rate of obstetric fistula. Cultural practices have been implicated. Early marriage, as we talked earlier on. Gishiri cutting, which is practiced in the northern part of Nigeria and the northwest among the Hausa community, where the traditional health attendants, the TBAs, are some of the traditional people practicing medicine, called the anterior vaginal wall in cases of obstructed labor, hoping that they are going to increase the dimension of the birth canal. Because of the lack of knowledge of anatomy, when they call the anterior vaginal wall, this also extends to the bladder and leads to obstetric fistula. In some places where they insert caustic chemicals into the vagina, it's also common in such places. Gender inequality / gender power imbalance, control of money and oppression of women. It's the men that control the money. Most of them, the women are housewives, they are not economically engaged, so they depend on the husband before they can seek health care, even in emergency situation. People that don't go to health facility for delivery, in other words, where there is no skilled birth attendance in such delivery, they are at higher risk of developing obstetric fistula. Study done by Thibault in 2012 found that people that attempted home delivery that have treated obstetric fistula in about 57.6 to 94.8%. While people that had a successful home delivery, the association of 9 to 84% with obstetric fistula. Female genital mutilation or genital cutting rarely causes fistula. This has been studied by some people, some researchers. They found that there are other factors that contribute to obstetric fistula formation rather than female genital mutilation, except where there is infibulation. In that situation, it can lead to or predispose somebody to obstetric fistula formation. When there is poor road network, long distance from place of residence to health facility also contributes to the risk of developing obstetric fistula. In Guinea, the median travel time to treatment facility is 24 hours, and the interquartal range of 4 to 48 hours was reported by a Landry study in 2013. In Nigeria, the median travel time to facility is 2 hours, with the interquartal range of 1 to 4 hours. So the longer the distance to the health facility, the less likely that person will utilize hospital for delivery. Insecurity on the road is very prevalent now in many parts of West Africa. And where there's insecurity, people are afraid to go out, especially at night, to facility for delivery. So in such situation, they either go to the nearby local hospital or to the traditional birth attendant, or wait till the following morning before they go to the health facility for delivery. So this contributes significantly. Lack of qualified staff, poor attitude of staff, and unaffordable services at health facility also contribute or are significant risk factors to development of obstetric fistula. Now we look at the causes of obstetric fistula. Obstructed labor, sometimes referred to as pressure necrosis. It's the most common cause of obstetric fistula. It is still very prevalent in the developing world. Other causes include cesarean section. If the bladder is not well reflected from the lower uterine segment, the surgeon may injure the bladder. Or in some difficult cesarean section like previous scar, when there is adhesions, all this also predisposes to that. Ruptured uterus. If the uterine rupture is on the anterior uterine wall, it can affect the bladder. Cesarean hysterectomy, forceps delivery, symphysiotomy, destructive operation are also possible causes of obstetric fistula. Gishiri cutting, insertion of corrosive substance into the vagina, and female genital mutilation. Pathogenesis. We are going to look at pathogenesis of fistula formation in obstructed labor, which we said is the most common cause of obstetric fistula. When the fetal head is impacted in the pelvis, the fetal head is hard. It compresses the anterior vaginal wall and the posterior bladder wall against the pubic symphysis, which is also hard. So if this compression is not relieved early, after some time, there will be lots of blood supply to the affected area. It becomes necrotic. Between the 3rd and the 10th day, the dead tissue sloughs off and now creates an opening between the urinary bladder and vagina. This is what we call obstetric fistula. Sometimes the compression may be against the posterior vaginal wall and the anterior rectal wall against the sacral promontory. If it is not relieved early, this will lead to a communication between the vagina and the rectum, and that is rectovaginal fistula. Now we look at the classification of obstetric fistula. There are various classification systems based on anatomical size, anatomical site, that is the location, the size, affectation of the continence mechanism, presence of circumferential defect, involvement of ureter, degree of scarring, probable complexity of repair. These are some variables that have been collected together in different classification systems. We have the WHO classification, YG classification, which is used in West Africa and East Africa, GOR classification used in East Africa, Tafesi classification, and others. These first three, WHO classification, YG, and GOR, are found to have the highest predictive accuracy of fistula closure. However, they offer poor to fair predictive accuracy. So in other words, there's still need for a standardized classification system, which some organizations are already working on. So let's briefly look at WHO classification of fistula. This classifies fistula into two groups: simple with good prognosis, complex with uncertain prognosis. The variables under the simple fistula include single fistula of less than 4 centimeters, just only vaginal fistula. The closing mechanism is not involved. There's no circumferential defect. There's minimal tissue loss. Ureters are not involved, and it's the first attempt. The complex ones, the variables under that, if the fistula is more than 4 centimeters, or they are multiple. If there is rectovaginal fistula, the fistulas are, we have the combined, that's the mixed fistula, or it involves the cervix. The mechanism for the closing is affected. If there is scarring, the circumferential defect, the tissue loss is extensive. If the ureters are visible in the vagina, if the repair fails before, or if it's following a radiation. All this belongs to the complex fistula, and prognosis in this situation is uncertain. So if somebody who is not very skilled in fistula repair, and you come across any case that has any of these variables under the complex fistula, that patient should be referred to an expert. So how do they present? The risk factors we talked about earlier on comes into play here. Teenage primigravida, short-statured women, women with pelvic deformity that belongs to socioeconomic class, and people who have attempted or who had unskilled birth delivery. So what are the symptoms? Most people will complain of continuous leakage of urine and or feces per vagina. Usually it follows a difficult labor, associated with stillbirth. The leakage usually starts between the 3rd and the 10th day postpartum. This is the classical presentation of obstetric fistula following obstructed labor. If it's from surgery, let's say following cesarean section, patient usually leaks urine within the first 24 hours. So there may be associated abdominal gait, which we call foot drop. Some of them have amenorrhea. There may be lower abdominal pain, loin pain, and fever. All these point towards urinary tract infection. The typical dysuria you get from a patient who are normal when they have urinary tract infection, you don't expect in this situation because they are not voiding normally. So the thing comes continuously, both day and night. So the only way you can get your symptoms is to ask for abdominal pain, lower abdominal pain, loin pain, and fever. Psychosocial complication is also common in them. So when one is taking history from patient, you cannot just do without taking psychosocial complication. Very important, and it's also important in your management of patient. There may be loss of, some of them there will be loss of self-esteem. They don't have confidence in themselves again. Everybody keeps away from them because they smell of urine. So some of them will develop depression. Family and social history is also very important. Many of them are separated, some are divorced. The husband that contributed to the problem, when the problem now starts, they will separate with the woman or divorce. Some of them are even rejected by their families. They cannot attend social function, they cannot go to market, they cannot attend meetings. So they become dejected and a social outcast. These are very important in history taking. Examination. General examination is important. You may be able to perceive the odor of urine, but sometimes it may not be possible in recent times because of availability of Pampers. So people who can afford Pampers, you may not perceive that odor in them. But since we say most of them belong to the low socioeconomic class, they may not be able to afford Pampers. So that ammoniacal odor is still significant. Some of them may be pale and febrile. Chest examination, all the examinations you do in normal person should be done in this situation. Chest examination is also important in the past because of the poverty. Nobody's taking care of them. They are not generating any fund. So they develop malnutrition and it exposes them to tuberculosis. But it's not common features in them again. Abdominal examination is important. Check for loin pain, suprapubic tenderness. All these points towards urinary tract infection. Musculoskeletal examination is important. You have to assess the lower limbs muscles, muscle power to exclude foot drop. The compression also may affect the lumbosacral trunk or the peroneal muscles, which affect the tibialis anterior and the peroneal muscles. The patient may not be able to evert the foot and dorsiflex. Vaginal examination, you start with inspection. Ammoniacal odor may be perceived. Perineum may be wet with urine. Usually it is wet with urine, except if somebody is using something like Pampers. Then look for vulvar excoriation. That is the rash you see around the perineum and the vulva. Then you do digital examination first before you do speculum. This is important to be able to assess the capacity of the vagina because there may be fibrosis, so that you know the right size of speculum to use. Otherwise, if you do speculum examination first, you may injure the patient. So mandatorily, you do digital examination first. This will guide you to know the right size of speculum to use. So during this digital examination, we want to identify the location of the fistula and the size, degree of the fibrosis, the capacity of the vagina. Speculum examination is done using Sims speculum in modified Sims position. So with that, you'll be able to visualize the anterior vaginal wall, where the fistula is. You have to use sponge holding forceps to help you to explore the anterior vaginal wall. After that, external examination is mandatory. And before that, you also examine the posterior vaginal wall from vagina. They now complete your examination with rectal examination. What are the different diagnoses of obstetric fistula from urogenital fistula? Genuine stress incontinence is possible. Somebody can also have that in postpartum period. But the difference in this situation is this is associated with increase in intra-abdominal pressure. So if you don't find any difference in the anterior vaginal wall, you must also test for that. The excess of activity, also known as overactive bladder, OAB, is also a possible differential and overflow incontinence. So in all these three, the anterior vaginal wall is intact. The investigations you do when you have a case of obstetric fistula, that is vesical vaginal fistula precisely now. You do the full blood count. You want to assess the renal function, so you do electrolyte urea and creatinine. The urine specimen collection in this situation is not the typical way of doing it, where you give patient bottle to go and collect urine. Since the urine is coming through the vagina now, if she collects the urine from the routine way, she's going to bring contaminants. So it will not be representative. So what you do is to do pipette specimen. You pass a pipette through the defect, that is the fistula, into the bladder and aspirate urine from there. If it's not available, in a low resource countries, you can use you can collect your urine from the catheter if it's possible, if it's going to come through that. Otherwise, you can improvise, use syringe. Expose the anterior vaginal wall by inserting a speculum. Then the tip of your syringe, you can insert it into the defect. This goes into the bladder, you then aspirate. This is improvisation. So that can be used for the microbiology test and also for urinalysis. Intravenous urography is also important. We want to see whether the ureters are normal or there's hydroureter, hydronephrosis. There can be this complication following obstetric fistula or vaginal fistula. Or sometimes, if it's a ureteral vaginal fistula, you can have an idea from that. 3D swab test is another test. It's a bedside test which you do. It helps you in ruling out some of the differential diagnosis. How do we do 3D swab test? Patient will be That is done in the bedside. We lie in a dorsal position, insert Foley's catheter into the bladder through the urethra. Put 3 swabs, one in the high vagina, mid vagina, and the lower third of the vagina, with the tip of the distal one projecting outward beyond the urethral meatus. Then you now instill about 100 to 150 ml of methylene blue into the bladder. You remove the Foley's catheter. You now tell her to walk around for about 10-15 minutes. After that, she comes back. You now remove the 3 swabs. Examine the 3 swabs and see if the 3 swabs are stained. It means there is a defect or there is a communication between the bladder and the vagina. That is one. It can also occur if there's communication between the bladder and the uterus or the cervix, because the dye will still come through the vagina, so it will stain the swabs. If the swabs are not stained blue and they are dry, it means the bladder is intact. So there's no injury to the bladder. If the swabs are not stained with dye, but they are wet, it means the bladder is intact. Most likely the leakage is coming from the ureter. And you think of that strongly if the patient has had abdominal surgery. So you can go a step further. In that situation, where you've examined, you could not identify any injury to the bladder, and she's leaking urine. And it's not stress incontinence, not overactive bladder. So you are suspecting ureteric injury. So you now ask the woman to take 200 milligrams of phenylsopyridine, that is peridium, orally. You insert swabs into the vagina, tell her to go and come back in 3-4 hours. When she comes, you remove the gauze. If the gauze is stained yellow, it means a phenylsopyridine test is positive. That confirms that the leakage is from the ureter. So it confirms ureterovaginal fistula. In some situations where the woman still complains that she leaks urine, you've done your clinical examination, 3 swab tests, you cannot identify the point of leakage. In that situation, she may need to do ureterocystoscopy. It may detect a small fistula. In addition, you will also be able to identify bladder stone if it is present. Preoperative management / supportive management of obstetric fistula. As you said earlier on, this is associated with a lot of psychological distress or problem. So you need to assess the psychosocial level of the woman, and she needs to be counseled properly. We also counsel her on treatment options. In the interim, we start her on Imatinix. You should apply zinc oxide to the perineum and the vulvar region to prevent dermatitis. And if she has dermatitis already, we use that for the treatment. Every patient that has an obstetric fistula, vaginal fistula, should have a bladder catheterization, except if the urine is not passing through it. If the fistula is small, it may close spontaneously. If it is large, the size reduces. Those people that have a foot drop, we start their physiotherapy at this time. Modalities of treatment of vaginal fistula. We have the conservative management, as well as surgical management. Conservative management, we pass indwelling urethral catheter for 4 to 6 weeks. This, for the small fistula, it may close spontaneously. So if there's no closure at the end of this period, then you say your treatment is failed. Other method is use of a cautery and bioglue. Fulguration is useful for small fistula that is less than 7 millimeter. And this may be followed with anticholinergic drugs, while the urethral catheter is still in situ for about 2 weeks. Success rate is about 75%, which is good. The other method is use of fibrin therapy, bioglue. This is also useful for small fistula. A fibrin-based surgical adhesive is used, that is the bioglue, and it seals off the area. Now we go to the surgical management, which is the common one. When do you repair vaginal fistula? Opinion is divided now. In the past, most fistula surgeons repair fistula after 2 to 3 weeks of insult. This allows for the slough edges to disappear. The tissue planes reappear at this particular time. And if there is infection around that area, you treat. This gives you better results. But in recent time, early treatment has been advocated, and it is also claimed that the success rate is good. The positions we use for surgery: you can put patient in lithotomy position, knee chest. All this is for you to get a good access. So that determines the position you want to use. The knee chest is used if the fistula is very low. And if the fistula is very high, that is not that going to be accessible, one may have to go through the abdomen. Then the other one is supine, when you are doing abdominal surgery. Prophylactic antibiotics regimen used in fistula surgery. Where there are various regimens. Some have done surgery without antibiotics. They record good results. Some have used single dose preoperative antibiotics, and some have used extended antibiotics, that's the therapeutic dose. There are various antibiotics one can use. You can use the simple, readily available, fairly cheap ones, like cotrimoxazole, aminoglycosides, and penicillin group. Randomized control trial shows no significant difference in fistula closure, hospital stay, infection rate, and fever among all these various antibiotic regimens I talk about. The route of repair. Well, you can repair through the vagina. That is what most gynecologists use. They are familiar with that area. The urologists prefer to go through the abdomen. Sometimes the gynecologists also go through the abdomen if the fistula is very high, that is not accessible per vagina. There's also a place for laparoscopic repair these days. And sometimes there's a place for combine, where you combine both the abdominal and vaginal approach. But this is not common. It's only in a very rare cases of complex fistula. What are the general principles of repair? Well, the fistula must be repaired by somebody who is skilled. So because you get the best result at first attempt. So if somebody just dabble into it and it fails, it makes the repair more difficult for the person coming to do it next time. There should be good exposure and accessibility. Sometimes you give episiotomy to improve your exposure and access to the fistula. The repair is usually done in layers. It should be watertight, tension-free, closure. At the time of repair, if the bladder neck is affected, one should make sure you reinforce that very well so that you don't have closure and patient will still remain incontinent. Then the patient should have a continuous bladder drainage for about 10 to 14 days. It provides high chance of closure. The cure rate is high when you do that. And there should be good post-operative care. It's very important. Choice of route of repair. This depends on the location of the fistula, as I said earlier on, accessibility to it, and the surgeon's preference. Vaginal route of repair. It has some advantages. There's less bladder dissection. There's less blood loss, less post-operative pain. It reduces hospital stay. There's better patient satisfaction, and there's no abdominal scare, which is a cosmetic advantage. There are some contraindications to vaginal approach. If there's vaginal stenosis, vaginal fibrosis, unsatisfactory access to fistula, if there's severe vaginal edge induration, or there is need for ureteric reimplantation, or you think there is going to be need for augmentation, cystoplasty in small bladder capacity. So now we look at the steps involved in vaginal route approach. Well, patient will have been clean drip and everything. One should watch out for and avoid ureters during repair. So before you start, you try and assess and look out for that. Well, we make a circumferential incision around the fistula edge. Some few fistula surgeons excise the fistula tract, but it's not necessary. If you do that, it provokes more bleeding during surgery, and the fistula size also increases. So problem of hemorrhage during and after surgery, and blood clots blocking the catheter is also there. So we make an incision, around the fistula edge, mobilize the bladder wall away from the vaginal wall, so that when closing, it will be tension-free, which is an important principle. Then when we close each layer separately, inverting the bladder wall into the bladder into the bladder, inverting the vaginal edge into the vagina. One, avoid the short ends into the bladder. And if one thinks the integrity of the repair is in doubt, or you think it's not strong enough, you can use a Marshall's flap to reinforce that. Then the other option too is the use of suturization. This is used for small fistula, or let's say somebody has had a repair before and there's residual. Suturization can be done. It's might just putting a pulse ring within the fistula and a tie, then now close the vaginal wall. The abdominal route approach. This can be intraperitoneal or extraperitoneal. The intraperitoneal approach is preferred because it provides better access to the fistula. It also gives access to ureters for easy mobilization. And it also gives somebody better bladder exposure. Omentum can be mobilized for interposition if there's need. Ureters can be accessed easily this way. And also, you also have access to the uterus as well. So post-operative care for patients that has had a fistula repair. The vital signs should be monitored regularly and recorded according to the protocol for the institution. Indwelling urethral catheter should be inserted intraoperatively and you leave for about 10 to 14 days. Intravenous fluid should be not less than 4 liters per day while she's still on the intravenous fluid. Then change to oral fluid, about 4 liters or more per day, if tolerated. You should keep an input-output chart. It will be well recorded. Attention of the nurses. Nurses must draw the attention of the doctors to it if the urine is not flowing well or you think the urinary output is inadequate. Patient should be placed on antibiotics if she's using the extended type. Analgesic is also important, that you don't look at it as being a vaginal surgery. She should have a good analgesic coverage. Early mobilization as soon as possible is encouraged. Pack cell volume should be done, and she should be placed on Imatinix. What are the causes of non-draining catheter? If the woman is lying on the catheter, the urine may not flow into the urine bag. If the catheter is kinked, it may be blocked by blood clots or debris, or catheter may be out of the urethra. So one should assess for all this and manage appropriately. If she's lying on it, tilt her and remove the catheter away from the position and put it where it will be free. If the catheter is kinked, then you adjust that appropriately. So what advice do you give before you discharge? All these are still part of post-operative care. You tell the patient to avoid sexual intercourse for 3 months. Not that she should be on contraception, no. To avoid sexual intercourse for 3 months. This is to allow for proper healing of the repair. And subsequent delivery will be by elective cesarean section. She should be well counseled. So that when she gets pregnant next time, she should go to a good facility where there's manpower and resources for cesarean section. Other treatment options available. One can use interpositional graft, as I said earlier on. If one is repairing per abdomen, then you can also make use of a mental patch if one thinks the integrity of the scar is in doubt, it's not strong enough. Laparoscopic repair is also becoming popular in the developed world. Use of posterior cervical lip for juxta cervical vesicovaginal fistula closure, M. Ijaya's technique. This is done when the patient meets the criteria for that procedure. The woman must be postmenopausal. It means she must have sustained the injury during the reproductive age period, but she's coming late for repair. She's coming in the postmenopausal period. Then one must have done a pap smear diarrheal cervical premalignation of the cervix or any abnormality of the cervix, and endometrial biopsy must have been taken to rule out any endometrial pathology before the patient will be qualified for this procedure. Other options include urinary diversions. The woman will be dry with urinary diversion, but there are some problems I'll share with it. These include recurrent ascending urinary tract infection, and also there's going to be possibility of reflux leading to metabolic acidosis, hyperchloremic metabolic acidosis. Then you have corpoclesis. The vaginal walls are posed together. The problem is she will not be able to have sexual intercourse again because the vagina will be closed. Then in recent time too, there's also a place for robotic surgery in advanced countries. This is in few cases. Now we move to rectovaginal fistula as a component, as one of the forms of obstetric fistula. Evaluation of patients with rectovaginal fistula. In the history taken, the passage of feces through the vagina, or passage of vaginal flatus, and or passage of malodorous vaginal discharge of fecal odor. On examination, this examination is going to be done, followed by the use of speculum and probing. Where the fistula is small, one may have to use probe to search for it. You insert the index and the middle finger into the posterior vaginal wall, then pat them to expose the posterior vaginal wall to visualize the posterior vaginal wall. Then you now do rectal examination. Look for signs of defect in the anterior rectal wall now. If there's any connection between the anterior rectal wall and the vagina. For tiny pinhole or unrevealed fistula, one might go further to do some specific evaluation, instilling dye into the rectum, and you see it coming from the posterior vaginal wall. There may be need for proctoscopy, or some radiologic study may be done, like barium enema vaginogram. Treatment of RVF. There's a place for conservative management. If it's a small one, it may close spontaneously, but most of the time patients are not patient enough. They want it resolved immediately. So, we have other conservative option using a endoanal plug. This facilitates spontaneous closure of the small RVF too. For the surgical closure, the principle of repair is similar to that of vesicovaginal fistula. In addition, you must have a bowel preparation before surgery, enema, suppository, and antibiotics. The route of repair, it can be done through the vaginal route, it can be done through the anal route, or transabdominal. Most accessible fistula, RVF, that is the low type, can be repaired per vagina. Then, if the repair integrity is not, one is not certain about that, you can use a mesh flap to reinforce it. For the high inaccessible RVF, transabdominal repair after temporary colostomy is advocated. For large previously failed repair, temporary colostomy may be provided before the repair. There's also need for good postoperative care. Postoperative care of patients that have RVF repair, they should be on inhaled pylorus for 48 hours preferably. Then we change to fluid-only diet, followed by low-residue diet. How do we manage people that have a combined or double incontinence? Opinion is divided, depending on the surgeon. Either to close both at the same time, which is advocated by some surgeons, but the problem is that if one fails, it may become difficult, especially if let's say the VVF fails. It may become difficult for somebody to repair it because of the repair you've done for the RVF, which compromises the space for you to access the VVF. But pain must be well accessed before going ahead. So there is a place for closing the RVF and the VVF at the same time. Some also prefer to close the RVF first, thinking that by doing that, you reduce soiling and allow you to be able to repair the VVF later. While some we prefer to do colostomy first to divert the feces, then repair the VVF. After repairing VVF and you've achieved cure, then now repair the RVF and close the colostomy. How do you prevent obstetric fistula? Primary prevention. This can be, you can look at it from that perspective, primary level care, then secondary level of prevention, and tertiary level of prevention. Obstetric fistula can be largely prevented by preventing obstructed labor, as it is the major cause of obstetric fistula. So if one can prevent obstetric labor from occurring, you are largely going to prevent obstetric fistula from occurring. So primordial/primary preventive strategies: health promotion and awareness, improve nutrition to prevent childhood malnutrition. By doing that, it means the pelvic bone will develop normally at childhood and it will be wide enough for vaginal delivery when the time comes. Try to alleviate poverty, provide a microeconomic scheme for the women, empower them. We want to encourage female education. By the time they go to school, by the time they finish secondary school, they are already getting to 18 years, go to further their education, go to tertiary education. By the time they are graduating, they are already matured enough for pregnancy and delivery. And that's another way of delaying marriage. Then there should be legislation against some negative traditional practices, such as female genital mutilation, gishiri cutting, gender inequality. There should be good transport and communication services. This will reduce the interval time from the referring hospital to the referral center. Prevention of early marriage, provision of family planning services that is accessible and affordable. This will prevent teenage pregnancy. It causes a spacing of pregnancy using contraceptives. Secondary prevention strategies, provision of affordable and accessible maternity services, both basic emergency obstetric care and comprehensive emergency obstetric care services. Provision of antenatal services. Every delivery should be supervised by a skilled birth attendant. Use of pathograph to monitor labor so that parent can be referred appropriately and at the right time. Early recognition of cephalopelvic disproportion and prompt cesarean section. Prompt referral of difficult labor cases when required. Skilled abdominopelvic surgeries and instrumental deliveries. So the healthcare provider should be well trained and they should always be attending regular retraining courses. By so doing, one will also prevent obstetric fistula. Tertiary prevention strategies: all prolonged labor cases should have indwelling urethral catheter inserted for about 10 to 14 days. And repair of fistula cases we should encourage healthcare providers to have skill for repair of fistula so that we can clear the backlogs. Then there should be proper rehabilitation and reintegration of obstetric fistula patients into the community. Well, we've talked about obstetric fistula. We started with the definition, look at the epidemiology and the risk factors, how prevalent it is in the developing countries. And we also mentioned that prolonged obstetric labor is the leading cause of obstetric fistula in developing countries. It is rarely encountered in the developed world because of their good obstetric care. The few cases seen in developed world is from surgery and some from radiotherapy. But surgery is the commonest cause of obstetric fistula in developed countries. We also look at how they present and how to investigate them, the various treatment options available, and the prevention of obstetric fistula. In conclusion, obstetric fistula is a preventable condition that is prevalent among the less privileged people living in the most remote part of the world. The mainstay of prevention is avoidance of obstetric labor and its attendant complication to improve obstetric care. These are the references. Thank you for listening.